Hello and welcome to the Boston Structural Heart course. In this Transeptal Puncture workshop, I'll be going over with you with the nomenclature and orientation of the inter-atrial septum. This topic is a little confusing and a bit more complicated than it seems, particularly in the era of multimodality imaging during procedural guidance, when we need to have the same nomenclature and the same reference points in the cardiac anatomy. So we have a lot of ground to cover, and we'll get right into the business end of this presentation. So the main questions that we'll try to answer in this presentation are, number one, why do we need to know this? Secondly, what is the true and the false inter-atrial septum? And secondly, is anatomical orientation the same for all modalities? And that's the most important part and the crux of this presentation. The outline of this talk is that we'll go over the embryology, the anatomy, orientation, and finally compare and contrast fluoroscopy and echocardiography. And at the last part of the presentation, we'll come to a reconciliation regarding the nomenclature of inter-atrial septum so that we are all on the same page, particularly so during complicated and procedural guidances for structural heart disease interventions. So a lot of this has been borrowed from this review article that we are very proud of that was recently published in the Journal of Cardiothoracic and Vascular Anesthesia that goes over the review of the inter-atrial septum, the review of the cardiac nomenclature, particularly in reference to transeptal puncture. So a lot of these graphics are borrowed from this article, in which we actually had original graphics and original animations, which I would highly encourage everyone to read this article in more detail. So what is transeptal puncture? So this is essentially the process of getting a catheter across the intra-atrial septum from the right side to the left side. Now, this is an integral component of left-sided structural heart disease interventions, and you can see that, as we've discussed in the past, that it is procedure-specific and it is patient-specific. So there has to be, in relation to what structural intervention is being performed, that the site selection of the transeptal puncture is performed during the procedure. So importance of the knowledge of the true and false inter-atrial septum is embedded in the embryology. And this is more important than we think, because once you understand the embryological origins, you'll begin to appreciate why this confusion and ambiguity regarding the false and the true inter-atrial septum nomenclature, as well as in its nomenclature, in its orientation in space. So let's go over the embryology first. So the true and false terminology of inter-atrial septum is embedded in embryology, and we'll go over this thing in just about a second. And this is one of those diagrams that is often published and widely circulated if you go to Google and look at numerous journals, which seems to be a very comprehensive and a complicated diagram, but trust me, it never made sense to me, until the time that I read in detail and then try to create an animation of the development of inter-atrial septum. So the next few slides are an animation of the development of inter-atrial septum that I drew myself and created myself for my own understanding, and they seem to make sense to a lot of people. So in the intrauterine development, primitive atrium is one continuous cavity, which is open in the cephalad portion, and in the caudate portion of the primitive atrium are the endocardial cushions, which look like this on view from the side, and view from the front, they look like this. Now, the first thing that happens is the formation of septum primum that comes from the cephalad portion and travels towards the endocardial cushions, but stops short of the endocardial cushions, and the hole or the orifice that is present between the caudate end of the septum primum and endocardial cushions is referred to as ostium primum. This is how it looks from the side. This is the entire septum primum. This is the endocardial cushion, and this is the ostium primum. Now, up to about the 6th week of intrauterine life, there is development of the SVC ostium in the right primitive atrium, and the left pulmonary vein and the right pulmonary vein appear in the left primitive atrium. At the same time, the septum primum advances further caudate to fuse with the endocardial cushion by the 6th week of life. While this is happening, at the same time, there's appearance of these fenestrations on the cephalad end of the septum primum that are referred to as ostium secundum for the transfer of oxygenated blood coming from the placenta to the left side of the heart. The next thing is now that we have a septum primum that has fused with the endocardial cushions. We have the SVC ostium on the right side, the left pulmonary vein and the right pulmonary vein. And by the 8th week, we also have the IVC ostium, and the pulmonary veins are further subdivided into left upper, left lower, and right lower pulmonary veins. Now, at the same time, one of the most important things happen, and that's the growth of two extracardiac septi that grow from the cephalad as well as the caudate portion on the right side of the septum primum into the primitive atrium. So therefore, this ostium secundum is closed by this extracardiac tissue, and this is on the caudate end of the septum primum, another endocardial cushion that grows. Now that's the most important part that relates to this true and the false inter-atrial septum. Now, if you look at it, this is the SVC, IVC. This is the right side, and that includes these two extracardiac fibrous tissue cushions that invaginate into the right side of the heart on the right side of the septum primum. And we have the left upper pulmonary vein, right upper, left lower, and right lower pulmonary vein. Ostium primum is closed. There is this septum secundum, and these extensions are called the septum secundum, which are essentially extensions of extracardiac space into the right atrium. This is the patent foramen ovale, which still continues to transition the blood from the right side of the heart across this flap valve in the left side. This floor is referred to as fossa ovalis, which is the septum primum over here, and on the right side are septum secundum, which are extensions of extracardiac space into the primitive right atrium. Now, if you can imagine, when a needle traverses from the right atrium to the left atrium from this location, it goes from the right side through the extracardiac space into the left atrium. The same goes for the needle in this location, and fossa ovalis is the only location where the needle can go from the right side of the heart to the left side of the heart without going to the extracardiac space. And hence, this portion, the septum primum, between these two septum secundums is referred to as the true intra-atrial septum, and these two extra, thick portions of the intra-atrial septum are essentially extracardiac space extensions and are referred to as the false intra-atrial septum. Now you put that in a diagram. This is a bicaval view of the mid-esophageal location of the TE probe. So this is the fossa ovalis. This is the true intra-atrial septum. This is the patent foramen ovale. And these two thick portions are referred to as the false intra-atrial septum, which are essentially extensions of extracardiac space. And if a needle was to go from the right to the left side through them, this would go through the extracardiac space first, causing a pericardial effusion rather than going directly into the left atrium. So this fossa ovalis technically is the true intra-atrial septum. Now we can look at it as we do during echocardiography for imaging of the transeptal puncture in the mid-esophageal four-chamber view. You can see these two extracardiac space extensions. This again is an extracardiac space extension. This is an extracardiac space extension, and this is more clearly seen on the superior and the inferior side of the fossa ovalis, so extracardiac space extensions, or the false intra-atrial septum. Now, we've already gone over the history of the transeptal puncture, but I'll briefly go in context to its embryology, and that was that André Frédéric Cournard, the famous cardiologist who actually won the Nobel Prize for developing the technique of right heart catheterization, was the first one to describe transeptal puncture, but that only in 5 human subjects who had pre-existing atrial septal defect, and they were able to safely cross from the right side to the left side to measure the left atrial and left ventricular pressure. So that was the first description of the development of a transeptal puncture technique. Now, when that happened, and when people realized the clinical value of knowing the left-sided pressures, all sorts of investigators developed very invasive and somewhat complicated techniques to get to the left side of the heart, which included, like in Dr. Koronan states from a pre-existing atrial septal defect, we had something going in the parasternal, route, the paravertebral route. The bronchoscopy was performed to go across the left mainstem bronchus into the left atrium, and finally, Ross et al. Developed the true transeptal puncture technique in the National Institute of Health in Bethesda, Maryland, in conjunction with Dr. Brownwald and Dr. Morrow. That developed a catheter that could safely be, go across the interatrial septum through the fossa ovalis, because it avoided the extracardiac extensions of the extracardiac extension spaces into the primitive atrium. So therefore, the technique and the knowledge of it that made it practically possible was deeply rooted in an accurate knowledge of the development of intra-atrial septum and the places to go through and the places to avoid. So that was the key part in it. And they published their results about the ability to measure the left-sided pressures and the clinical value in the future of this particular technique. Now, the anatomy of the fossa ovalis is a little bit, underwhelming, because technically it's a very small space or a very small portion of the interatrial septum. So the interatrial septum consists of the false septum and the true septum. What we are concerned for transeptal puncture is the true interatrial septum. So this stipulated area that you can see essentially is the true interatrial septum. As you can see, it is somewhat about 1.2 centimeters across here and about 1.5 centimeters across in this space. So it's a very small technique, and it's a question of millimeters of precision that is required to have the needle pass exactly at the location that you want to facilitate your structural heart disease intervention on the left side. And as you can see, it is bordered by the IVC, the coronary sinus, the tricuspid valve, the superior vena cava, and the non-coronary sinus of the aortic root. So we'll go over all of these things in just about a small detail. So in this porcine dissection that we created, we've tried to recreate this picture in this sense in showing the tricuspid valve, the coronary sinus, the ostium of the IVC, and finally the fossa ovalis, that is the true intra-atrial septum in the middle over here. And if you take out all the labelings over here, make this a clean diagram, you can see that the margins or the orientation of the interatrial septum or its margins and edges are performed in relation to the bordering structures, and that's where a lot of confusion arises in what is superior and what is inferior. Now, if you were to take that anatomically, bring in an anatomically correct illustration, you can see that the bordering structures are indeed the superior vena cava on one side, the inferior vena cava on the other, the coronary sinus, the non-coronary cusp of the aortic valve, and finally the vault of the interatrial of the right atrium. And now, the embryology and the anatomy is depicted in how the anatomy is described. The famous anatomist and artist Leonardo da Vinci described the Vitruvian man with an en face view of the human anatomy when viewed from the front. And it is classically described as in an upright posture, and the observer is observing the anatomical model from the front. You would go right across the middle, you have the medial in the middle, the sides are lateral, there's anterior and posterior, and superior and inferior, and this is all from a perspective from being seen from the front. And that leads to the Valentino description of cardiac anatomy and the way we are taught in medical schools, and that is as though we are holding the heart in our hand with the apex of the heart facing the pointed towards the ground. Now that is, while anatomically is an incorrect orientation, but that's how the anatomy and the terminology has become entrenched, giving rise to the right and left and superior, inferior, and medial and lateral terminology in cardiac, anatomical description when it doesn't exactly exist. So the Valentine position, the apex is facing the ground. There's superior portion. Sorry about this. There's superior portion. There's inferior portion, medial and lateral, and left and right. So that's the Valentine description of cardiac anatomy. That's how we are taught, but has very little to do with the way the heart is oriented in the mediastinum. And the reason for this thing is that while we describe the human anatomy in coronal, sagittal, as well as in horizontal or transverse planes, the cardiac silhouette, while we like to draw these axes around it, does not share these coronal, axial, or sagittal planes with the rest of the human body. In the attitudinally correct position, the apex is actually, facing anteriorly or superiorly and tilted towards the left. And there's an anterior and posterior description to the cardiac, ventricles and atria as opposed to the left and right. So this is a little bit more complicated, attitudinally correct, and a lot of anatomists have written a lot about this attitudinally correct disposition. And if you were to see the way the cardiac silhouette is oriented in the thoracic cavity, the right ventricle is actually not right, but the anterior ventricle. The anterolateral papillary muscle in attitudinally correct position turns out to be superior and posterior, and the posteromedial papillary muscle is inferior and anterior. So it's a little bit more confusing if we were to describe the cardiac anatomy in relation to the way it is oriented, its silhouette is oriented in the mediastinum in relation to the rest of the body. And now comes to complicate further is the echocardiographic position, which is, while it is, depicted in a much more complicated fashion, but seems to correspond to the Valentino description of cardiac anatomy, with the apex facing down, and you see the right and the left ventricles in a side, and we'll soon visualize that in a second. As you can see in this specific diagram, while it is a mid-esophageal four-chamber view, which is being shown here, but at the same time, you are at the back of the heart, and you are looking up. So therefore, you are not only being, flipped upside down, the image has been flipped left to right to give you the description, or to conform into a Valentino description of cardiac anatomy, where the apex faces the ground. This is the right side, this is the left side, and in the middle come the inter-atrial septum. So therefore, we can technically, this portion, which we consider the lower portion, is actually the superior portion of the inter-atrial septum, and this, what we refer to as the inferior portion or the posterior portion, is actually the more, inferior portion of the ventricle. So having said this one, if this is the orientation of the cardiac silhouette in the body, and the way it is described in the mid-esophageal four-chamber view, and when we are looking at the septal indentation, we call that as septal height. Technically, this is septal depth, not the septal height, because in absolute space, you're not moving up in the inter-atrial septum, you are actually moving down on the inter-atrial septum. So that's a little confusing, particularly so when two people are looking at the anatomy and describing it in different orientations. And that comes into play specifically when we try to conform the echocardiographic anatomy to the fluoroscopic anatomy. So for example, when we have to have a catheter move from the left atrium across the mitral annulus into the left ventricle, our terminology that we use is start in LA, go down through the mitral valve, further down to the mid cavity, and finally to the apex of the heart. But technically, you are going through the left ventricle, up to the mitral valve, into the mid cavity, and finally at the most superior anterior portion, and that's the apex of the left ventricle. So that's a little confusing. Now let's get into why this is important to know, and that's the fluoroscopy versus echocardiography in your debate. The fluoroscopy are essentially projections, which means you look at a three-dimensional anatomy, put it flat on a two-dimensional screen, and then you assess the position, that's the left, the right, the superior, anterior, in relation to their absolute position in space by their relationship to catheters and position to the camera and the gantry that you use in the room. Whereas echocardiography is tomographics. It's the tomographic sections of the heart with very precise location in relation to each other. And you see that in X, Y, and Z axis, particularly so when you're using three-dimensional echocardiography. So therefore, as you can see, that the X-ray tube is in the front. This is the primary radiation. This is the detector. And that leads to the projections of the LV, the RV, the fossa valis, and the right atrium and the left atrium in a plastered fashion in a single dimension on the screen, which does not conform to the tomographic display of anatomy that we see during echocardiography. For example, in the anterior oblique projections, you can see that the left anterior oblique projection, you can see that this is how we see in three-dimensional echocardiography. And this is how it is displayed in the inter-atrial septum. And if you really want to conform your three-dimensional image to the fluoroscopic projection, the way the SVC and IVC oriented, during image acquisition, I've tried it myself, you not only have to flip the image left to right, but turn it upside down and then do a three-dimensional reconstruction, and then you'll get something which conforms to the same image as the as the left anterior oblique projection. The same goes for the right anterior oblique projection. If you get the 2D image, first flip left to right and upside down, and the machines allow you to do that, and then do a three-dimensional reconstruction, you'll get an image that conforms exactly the superior vena cava exactly in the same location as the inferior vena cava and the inter-atrial septum being seen en face in the right anterior oblique projection. Now we bring the most important point, and that's nomenclature. So the unresolved questions relating to the cardiac anatomy, the way it's oriented, that is the attitudinally correct position, the Valentine description that we all have been taught, as well as the echocardiographic display of anatomy, and then to throw in a little complexity of the tomographic or the projection nature of three-dimensional anatomy during fluoroscopy. So the key is, what is more important? The actual position in space, the attitudinally correct anatomy, or the position on image display as you see in the screen? That's an unresolved question. For example, we tend to think of the fossa ovalis as having superior vena cava, inferior vena cava, showing the superior and inferior margins of the coronary sinus over here. And then once we look at the orthogonal view of it, we tend to look at the superior rim of the fossa ovalis, the inferior rim, the aortic valve signifying the anterior rim, and then this goes over here as the posterior rim. This is a classic description of an anatomy as we learn on it. And we tend to think of these superior, inferior, and anterior and posterior structures as being perfectly right angles to each other. However, in this anatomically correct graphic of some simulator, you can see that while the aortic valve is thought to form the anterior margin and the superior vena cava as the superior margin, they're not exactly orthogonal to each other. They're essentially at about only oblique axis to each other, and therefore it can be confusing. And as you can see, even in this dynamic display of anatomy, both the superior and the inferior margin, superior and the anterior margin are lying essentially side by side, and they're not exactly at orthogonal descriptions to each other. If you keep going, you look at that in this display of the superior and inferior margins, as well as anterior and posterior margins, that while we think of them as having complete orthogonal relationship, like geometric structures, this is not the case in this situation. So therefore, our classic description of anatomy, as we learn, which is based on superior vena cava, inferior vena cava, showing the superior and inferior margins, and anterior and posterior margins, are somewhat correct in relation to what we see in relation to those margins, but not necessarily true of their absolute position in space. For example, as you can see in this one, this is the superior margin, this is the inferior margin of the fossa ovalis, and this is the aortic valve here, which is, it could be anterosuperior or supra-anterior, whatever terminology you may use in relation to it, but that's still unresolved. Same goes for the posterior and inferior margins. As you can see, this is the anterior margin, this is the posterior margin, the aortic valve, and you can imagine this being the right atrium, this is the IVC, and this is exactly the entry of the SVC. So therefore, the anterior and superior margins are not exactly orthogonal to each other. So these are those graphics that I referred to in the first part of our article, that you can look at anatomically correct, graphic descriptions of the orientation of the SVC, IVC, as well as the aortic valve. And the same goes for the fossa ovalis when looked at it from an attitudinally correct position. So essentially, when we come down to its practical value of this nomenclature, we tend to describe the fossa ovalis in a superior margin, an inferior margin, anterior margin, and a posterior margin, and then we call something as height or the depth or the height of the transeptal puncture in relation to indentation that we are able to demonstrate. So therefore, the high and low, as anatomically incorrect it may be, is seen in the metaesophageal four-chamber view. We tend to call this thing as the height of the septal puncture, but I would propose that the correct terminology, which does not have any ambiguity, should be the annular distance of the septal puncture, so that we do not have any terminology debate or confusion of what we exactly mean by this one. So this is the anterior and posterior, which should be referred to as the aortic and the posterior margin, and this should be the SVC and the IVC margin, which are seen in these sections are being shown with this graphic displays on this fossa ovalis. So the main question is, why do we need to know this thing? Because we are in the era of a multimodality imaging when we all need to conform and not use terminology such as move up, down, or to the left or the right, or superiorly or inferiorly, but rather be very specific about our motion of our catheter when we are telling someone you should go towards the aortic margin or the SVC margin or the IVC margin, rather than saying go anteriorly, posteriorly, because that could mean different to different people in relation to its position in absolute space or in relation to what is being displayed on the image. We learned about the true and the false inter-atrial septum. True septum being the fossa ovalis, where you can go from the right to the left side without going to the extracardiac space. And the thick portion of the inter-atrial septum is essentially the false inter-atrial septum, where crossing this thing can be very hazardous because you go from the right to the extracardiac space and then to the left side, creating pericardial effusion. And then finally, there is anatomical orientation. Is the same for all modalities? No, it is not, because it is quite different. One is a projection, one is a tomographic display, and therefore to conform and to reconciliate them is very complicated. Therefore, it's more important to be very precise in your guidance during transeptal puncture and other techniques of what you refer to as your reference points. Why do we need to know this? Because septal puncture is an integral procedure. It is central to all left-sided interventions, and precision is an extreme requirement during this one. So what is the true and the false? Again, false inter-atrial septum from RA to extracardiac space to LA. True inter-atrial septum is from LA to RA directly. Anatomical orientation, T, without being explicit, conforms to the Valentino description. Fluoroscopy is an absolute position in space rather than on the echocardiographic position. Bottom line is we need to reconciliate these things. And the purpose of this reconciliation is not to criticize and recreate the anatomy because it's too far entrenched to be revised anymore. We do not need to, find a new anatomical nomenclature for the cardiac, but we need to at least understand the differences on the basis of the principles of the anatomical nomenclature for multiple imaging modalities that we use in the operating room during procedural guidance. So to finish it off, in the words of Giordano Bruno, there's no absolute up or down, as Aristotle taught. No absolute position in space, but the position of a body is relative to that of other bodies. Everywhere there's incessant relative change in position throughout the universe, and the observer is always at the center of the things. So the rims of the fossa ovalis, according to my description, would be this would be referred to the SVC and the IVC rim. This would be referred to as the aortic rim. This would be referred to as the annular distance from the mitral of the transeptal puncture, rather than saying anterior, posterior, superior, inferior, or height or depth of the septal puncture. Thank you very much.